Everybody has taken the chair. I will start. So, this is the 53-year-old gentleman having ECOG1. There is no comorbidities. There is some addiction, maybe around 10-15 years of smoking BD. And apart from there is a small complaint of some cough and this thing, and it has been imaged. So Virender, when some certain set of patients comes to you, you directly advise a CT or X-ray, or how do you proceed with these kind of patients?
Hello. Yeah, most of the time when we see a patient, they usually have investigation done outside. So if they already have CCT, that is good enough to characterize the lesion. Suppose there is only respiratory complaint but no imaging, or only chest X-ray, then obviously we'll first ask for a CCT thorax.
Okay. Nivedita, now you can see that the chest CT has been done, and Janita also. What do you think that we have gone through that, whether it is looking like a high risk lesion from the perspective of being malignant, or it looks to be okay just to leave alone, or maybe we need to go ahead with the biopsy? So what we need to do in these kind of lesions?
So morphology wise, definitely the lesion looks suspicious because it is solid and speculated margins are seen. So biopsy cannot be obviated, but definitely morphology wise, this is suspicious.
Janita, you have the same thought, or you feel that it's could be
Yes,
something
sir, but
else?
I would also like if we can see the mediastinal window to see how the enhancement pattern is, or
So this
yeah.
is the mediastinal window.
Yeah, so it's a solid lesion. I would want to biopsy this, and he's a smoker. He's got emphysematous changes, so my suspicion for malignancy will be high.
So can you tell me what are the features that actually, when you are looking at these lesions, will predict that this is going more towards a malignancy?
So speculated margins, heterogeneous enhancement, if there's necrosis, if there's an endobronchial invasion, or there's any chest wall or
Yeah.
mediastinal infiltration.
So we can see that these notches, these tags that we are actually having, and these speculations. So if these are there actually in any lesions, the positive predictive value that this might be turning out to be malignancy and possibly adenocarcinoma is around 80 to 90%. So this is the pre-workup history and the plan that was actually there, and the biopsy has been done. And just to Rajiv is on board actually. Rajiv, do you think what it looks like? Rajiv is there? He's not called inside. So actually I will just, okay. Rajiv, we are waiting for you. So Rajiv, this patient has this imaging, and there was a suspicion that this could be malignancy. Just need your thought what it looks like on the biopsy slides.
So on biopsy, what we can see on the left side, there is a tissue core of the biopsy which is showing a tumorous proliferation, and which is arranged in predominantly in the glandular architecture. So based on the morphology, I will suspect it to be adenocarcinoma, and to reconfirm this is from primary lung origin, we'll do ISC for TTF1. And if it's the next image is of TTF1 of this, and
Yeah.
it is it confirms to be of primary pulmonary origin.
Okay. So it is just done that we have the biopsy just from the point of metastatic workup, both from Virender and Anil. What we do next actually in this patient?
If the biopsy is adenocarcinoma and the lesion size is approximately 4 centimeter approximately, then we would like to do the PET CT scan and also the MRI brain. It's just to rule out the distant metastasis in a proven case of lung cancer.
Okay. So this has been done. Nilindu sir, do you want to highlight in the PET scan whether what stage it looks like?
I think just from the images available, there appears to be a single focus of uptake where the nodule was seen on CT scan. So I believe it's localized disease only with no uptake in the mediastinum or elsewhere in the body. And also you have written it stage T1, N0, M0. So.
Yeah.
Thank you.
So I just written that thing just to make some confounding biases. I just want to know how good is PET in actually telling the T descriptors, so that we have discussed about that it will help in certain scenarios, but how we can actually talk about these in T descriptors, so that it looks like it is going to be a T1 case here.
So for a T descriptor, I would, for the size criteria, I would actually rely on the CT itself, as I mentioned in the lecture. PET in this particular case, I guess would not be very useful. It would be mainly by CT criteria only. The few occasions where where a lesion is close to the mediastinum or to the chest wall and pleura, where there could be some subpleural atelectasis and all, there sometimes PET can help differentiate whether that tissue is actually tumor or whether that tissue is atelectasis or consolidated lung. But mainly T staging is by CT criteria only. It's very rarely does PET help when there is a lot of consolidation around it and you want to differentiate the tumor from surrounding atelectasis by differential uptake between the tumor and the non-tumoral tissue.
Yeah. So sir has highlighted where actually it can help, but we will go ahead and case and then we will again relook at the images. What is your opinion that in this particular case there is any need for invasive mediastinal staging? Kunal, Anil and Virender.
So Amit, just what was the T stage in this? T1 it was? Size, okay.
Size it was there actually, but there are many descriptors. We will see what happened to the case.
No, I thought it was relevant to the next question here.
So looking at the scan, peripheral T1 and 0, I think we'll avoid any sort of invasive mediastinal staging as far as with our current available information.
Yeah. So for only certain set of lesions actually we can avoid, we need to know that. But if these are not the routine cases in which it is falling, apart from everything else, the EBUS will be the main modality to stage the mediastinum followed by mediastinoscopy. And I think this is how the patient actually, we have worked up and everything, and the patient was complaining of there is some pain in the right forearm just before the surgery. So, and I will show these lesions again actually. So whether there is anything that looks like that could be the cause of pain anywhere else in these scenario, Nivedita, Jinita, or you would like to do something else?
Yeah, MRI.
MRI.
Because it's a right upper lobe lesion, so I would like to look at the brachial plexus.
Yeah. So we have just reconstructed these images. Are these going to be helpful before going for MRI?
So seeing these images, I would more so like to do an MRI, because these it shows that there is a pleural infiltration for sure. I would like to see if the nerve roots are also infiltrated.
Yeah. So see, it looks like that on the Excel images, sometimes these can hide the information. Multiplanar reconstructions, actually if they are available, it helps significantly for the planning of these patients. And what we see here is that the planes that are actually with the chest wall are actually lost. There is subtle soft tissue that is there, and this is the area where there is going to be the brachial plexus. So again, then we will look at the history. The earlier plan was that we will probably do with the lobectomy, and that we have discussed it. And then subsequently, we think that things have been changed. So this was the pre-workup plan. And the post-workup plan was something in which we have decided that there might be involvement of the brachial plexus and there is a need for opinion of the RT, and this was the final plan. I will show these images. I think these will be much more certain about what we are actually talking about. Jinita, can you tell us the findings that actually we are seeing on the MRI?
Yeah, so I would actually at this stage, as you've written upstage, because there is chest wall infiltration, there is extrathoracic extension of the soft tissue, and I'm not able to comment on the rib, but there is definitely involvement of the brachial plexus as well as the vessels probably that are exiting from there. I think that's the
Yeah, and I think Nilindu sir has highlighted very clearly in the lecture that there are certain set of areas where MRI can help significantly, especially when we are talking about relationship with the mediastinum or maybe in the pancreas tumors, probably in these locations. To Virendra and Anil, Virendra, how these things are actually common and whether this is a routine that we will do MRI in these scenarios, and what is your call, whether it is a symptom based or it is something else that you will decide it?
So, as you said, MRI has very selective indication for staging primary. Superior sulcus is one of those things where we need to look for if there is any abutment or involvement of first rib or disease is going into base neck, then obviously MRI is indicated in such cases.
So Anil, you would like to proceed with the surgery, Virendra, or you want to pass it to Anil actually?
See, we'll need the help of the radiologist, as you said, that whether the mass is infiltrating the brachial plexus or not, and whether my thoracic surgeon would be able to dissect it out, so without causing much damage to the brachial plexus. If that is a doable thing, that the mass can be dissected off from the brachial plexus without causing much damage. I think neoadjuvant chemoradiation therapy followed by surgical assessment is one of the treatment approach that has been routinely practiced in the pancreas tumor. Or if the patient, say for example, brachial plexus is already involved and they can't remove the tumor without causing much more damage to the brachial plexus, then I think it's a non-surgical treatment would be much better as compared to the surgical intervention.
So just for the Nandini, what is the neoadjuvant therapy that we can apply in these certain set of tumors along with the RT or maybe before RT?
So if we give neoadjuvant chemoradiation, most commonly we use paclitaxel carboplatin which is for the ease of administration. That is neoadjuvant followed by surgery if it's a pancreas tumor. But in not cases not like this, but select cases where there is a mediastinal node positive, and the few patients that we give, it is usually a cisplatin doublet. It might be paclitaxel, which we commonly use with for the squamous, and if it is an adenocarcinoma, a non-squamous, then pemetrexed with cisplatin. Those are the select patients which we give as neoadjuvant. But there is a lot of now evidence for use of neoadjuvant immunotherapy in combination with chemotherapy with or without. That is, there are some studies which look at only neoadjuvant, say nivo-IP prior to surgery versus pre and peri-op immunotherapy that is coming up for neoadjuvant therapies or even in resectable cancers. And if it is concurrent and non-surgical, completely non-surgical approach that we use generally for stage 3, then we commonly use etoposide platinum, that's cisplatin, or paclicarbo if the patient is likely not to tolerate the etoposide platinum doublet.
Just for the Rajiv actually, this is in the location where there are pancreas tumors and usually the histologies are going to be squamous. How common is that adenohistologies involve the chest wall, go and involve the brachial plexus?
So if we see the, so earlier we used to say that squamous is the common histology, but with now more advent of the use of the ISCs, and in this we are seeing the trend of adenocarcinomas on a rise. And so if you see a case, the trend in the late 90s or 2000, the squamous carcinomas were more common, but now around 60 to 70% are adenos. And the tumor, although biology-wise it looks like squamous, but on final histopath. So that's why the histopath is considered to be gold standard, and we have to rely on the pathologist.
We are relying and we are considering it as a gold standard.
Yeah, so both can have a variable or overlapping profile. So I'm not saying based purely on you should not go purely on the imaging that it has to be squamous, but there are some soft pointers which you always tell us that on imaging it looks like squamous. And
yeah. So it is a peripheral.
Amit, before please. I'll just, sorry, you are the master, but one question to Virendra. So we'll do an MRI and we'll tell you that there is involvement of the rib or the brachial plexus. Now, is there an absolute contraindication for brachial plexus involvement? Is suppose even C7 is involved or T1 is involved? So where would you say that involvement of brachial plexus is an absolute contraindication, or just involvement of one peripheral root of or nerve or cord or division is so because there's some literature where some people say that certain involvement up to certain stage of brachial plexus is resectable, whereas above C7 or something like that, it is not involved. So is there a criteria which you want us to tell about how much of brachial plexus involvement, or just involvement of brachial plexus means it is non-resectable?
So if we see this case, sir, so it is not very medial. So I am not expecting that the nerve roots are involved. Here the trunk or the peripheral part of brachial plexus involved. If the lesion is paravertebral, then T1 posterior root can be sacrificed. But anything above that is, relative contraindication for surgery. Here it is more of a peripheral kind of, not very central. So here surgery mostly no.
So you would want us to give the details of the brachial plexus involvement also. Okay.
Yeah, and I think the same thing applies for the radiologist as well, because this is a very critical information, and only looking at the axial images, we might miss the information sometimes, and that's why when we actually look on the scan into the multiplanar reconstructions, we might be more wiser and actually better describe the relation and extent of the tumor, because the T descriptor is not only about the size, it is also about the involvement of these surrounding structures, whether it is a pleura, chest wall, vertebra, and mediastinum, or maybe the nerves that are actually going in that locations. So I will, this is something which is CTRT that we have discussed it. This is the similar case actually. I think I just want to go away with this thing that the patient was having something in the knee joint. There was a lot of tenderness actually around that region, and this is the MR. Why I am showing, we will discuss it later, but Virender, have you seen something like this that comes to you, that there might be something which much more aggressive, or maybe the Jinita and Nivedita, that you can highlight that there are multiple lytic lesions that are there in the bone? The patient presented with this.
Sir, in my practice, I limit my radiology to chest X-ray. So, Jinita.
So these are multiple osteolytic lesions, and this was the chest X-ray done for something else. So what it looks like actually, now I'm providing you a chest X-ray.
Yeah, this looks suspicious, sir. Bilateral nodular opacities are seen. So looks like if there is the previous one was of same patient. So in such cases, I'll suspect some CA lung with metastasis.
Yeah. So this is how it was evaluated actually, because it has went to the pulmonologist and they have done a lot of battery of tests and everything, that CRP, TB expert, this, that and everything. They have done the bronchoscopy and everything was actually negative. The main thing is that this was the CT. Nivedita, and would you like to take that case?
Yeah, so there are innumerable pulmonary nodules, lytic lesion in the bone, and I suppose liver mets also.
Yeah.
So liver lesions, so yeah.
So this is how sometimes actually the patient can have a metastatic, the presentation with going to be with the metastasis. In this case, it was the presented with the acral metastasis, which is actually far below that. It was having studied, earlier labeled as miliary tuberculosis, and actually when the scan was done, actually it was showing a large mass into the left hilum, and these are the multiple metastatic sites. We did a biopsy from the tibia, and that turned out to be metastatic adenocarcinoma. So what you would like to do next actually when it comes to the medical oncologist? So now this is the presentation when we are having a lot of metastatic disease, and there is a lot of lung metastasis, liver, another metastasis. Histology saying it is adenocarcinoma.
So this is an adenocarcinoma which is metastatic and it's proven. So in today's era, we need to know whether this tumor is a driver mutation positive versus not. We anyway would take history of smoking and other things, but it's not hard and fast that all smokers are driver mutation negative. So we would at least do the two most common driver mutations in an ideal scenario where we try to do it in most of our patients at our center, get an NGS, because when tissue is limited, especially in a bone tissue, bone biopsy, there may be issues with getting DNA for assessment for molecular testing. But the first thing is to look for a molecular driver and a PDL1, which would be our basic investigation. Whether we would start chemotherapy immediately or wait for results, it depends on the clinical assessment of the patient, how symptomatic he is, any crisis that is there, like if he has he's on oxygen or he needs, then we may start chemo and wait for the results and then modify it accordingly. Otherwise, if in very stable patients, we can at least wait for the PDL1 and EGFR ALK at least before we decide to start on chemotherapy. And then once we have this data, accordingly we proceed based on the results.
Yeah.
And an MRI brain also to rule out brain mets and then proceed if he needs radiation or if they're symptomatic and accordingly.
Because Kunal is sitting idle, I will ask him whether he would like to biopsy the lung lesions, liver lesions, or the bone lesions, which is a better approach to target these lesions.
Liver, obviously whenever liver is seen, ultrasound guided liver would be much more easier compared to the risk of complications are pretty much lower while doing liver biopsies compared to the lung, where the pneumothorax is, because here there are multiple small nodules and to target those small nodules would be difficult, plus there is chances of pneumothorax which can happen because we are targeting very small nodules.
Okay, so it has been targeted from the tibia because they want to know that whether that is also a site of the metastasis, and
the patient would have gone to orthopedic oncosurgeon and then they would have biopsied.
Yeah. So Nandini, this is the profile actually. So lot of things has been done actually, and there was a need for urgent initiation of the chemotherapy that has been explained to the patient. Everything was actually, I think, almost negative. What one would do in these kind of scenarios actually?
So this is the IHC report alone, which has actually assessed only ALK and ROS. So for ALK, this is adequate to decide whether you want to treat therapy or not. More or less, it's concordant with other testing methods. But for ROS, if it is negative, it's fine. If it is positive, it had to be tested with the fish for ROS again to confirm. And the PDL1 is negative, so that is known. But we would also look at EGFR, which is not detected on IHC. That's not the recommended method either on NGS or an RT-PCR. And of course, rare mutations like HER2 and BRAF, NTRK, KRAS, which are also not detected on this IHC. So we need to look for the molecular results on NGS or whatever. Like if we have not sent an NGS, at least if we have sent the EGFR, RT-PCR, we need to look at those. But if it's a symptomatic patient, we probably would not wait for the results. We would start chemo immediately and then go on and then modify the therapy based on whatever we got. This patient, if he was EGFR positive, would probably go on an EGFR inhibitor plus or minus chemo. If everything was negative, then chemotherapy with or without immunotherapy is approved even in PDL1 less than 1 or all comers. So if there are no other feasibility issues, that would be the standard of care for him.
Yeah. So thank you. There are multiple options that are available to these patients now, and actually the patient defaulted in between. Then when he presented later, he was quite symptomatic with cough and hemoptysis. There is a large lung mass that has come, and then actually he could not be revived actually. To Rajiv, just asking you to know that if we are targeting from multiple sites, regarding these biopsies from multiple sites, whether there is any change in the mutation profile or something like that that is feasible, or whether we have to target always from the pulmonary site first and then try to look whether there is any marker that is going to be positive.
So you want to bring about the concept of heterogeneity here. Yeah, so it is recommended in the lung, whatever the easily accessible site, you should try to do that. The heterogeneity or the difference in the expression profile can occur, but for practical purposes, it is not feasible to biopsy all the possible areas. So it is recommended whatsoever the accessible site, you go as per that profile. And another thing which can be done is to do the liquid biopsy, because that covers the limitations which might be there for the due to the tissue, and the issue of heterogeneity can be addressed. And there are now very sensitive assays platforms which can pick up. The only limitation of the liquid biopsy, if it is positive, you can regard it as a definite, but if it is a negative, then you have to go back again to the tissue.
Okay. Just to Anil, actually, if we are planning for some palliative RT because the patient is symptomatic, what are the options that are available to this patient?
I believe the patient was symptomatic for the leg pain and the knee joint pain. So we can offer him the palliative RT to a dose of 8 gray single fraction or 20 in 5, depending upon how much is the life expectancy of the patient. If the patient would have survived, say for example, if Nandini would have done the NGS and it would have come EGFR positive, so the median life expectancy of an EGFR positive physician is approximately 3 to 4 years. So we would like to have a durable local control as well as pain relief. So we would go for fractionated palliative radiation therapy as compared to single fraction. But as if the patient is has a very limited lifespan, so 8-day single fraction is very much good enough as far as the pain control is concerned. So 8-day single fraction versus fractionated radiation therapy will be good enough for the palliation of the pain.
Okay. Just to Nilindu sir, when we are having such a metastatic condition, whether there is any mean that whether it is going to be a EGFR positive, are there some patterns which will decide that this patient might have a EGFR positivity, might have an ALK positivity, based on the morphology as well as the metabolic uptake that we see?
So, on the basis of, there are papers and all which say that certain type of metabolic uptake would suggest kind of a surrogate marker of all these molecular markers, but actually I have not, in practical day-to-day clinical situations, it really does not help. Morphologically also there are descriptors, but I don't know how much you can rely on them. One thing which of late we have started doing, just yesterday we did few cases, we have now developed a molecule which is called PD-L1 PET. It kind of is a surrogate expression marker of PD-L1 expression. So those things are there. On FDG it really does not give you much information about these different driver mutations. Morphologically, I guess probably Nivedita or
Nivedita, you want to add something, that are there any specific patterns that we can recognize on imaging or maybe on the radiomics or something like this, which we can actually segregate the EGFR and the ALK, and maybe they can initiate the therapy earlier before actually we can take the results from the pathologist?
So EGFR generally presents with, if I'm not wrong, round glass opacities, whereas ALKs are usually solid. May not be 100%, but usually bilateral. If they are ground glass opacities, they are more likely to be of EGFR mutations, whereas ALKs are usually solid, larger in size. That's what till now we have known in literature.
Okay, I think it is not still developing that the imaging might recommend that there might be certain set of patterns, or maybe with the use of AI with the larger data sets, when we are actually feeding some data, we might get some answer that might be the threshold of giving the ALK or EGFR positivity, but it is yet to be explored. I have more questions, but only time is 2 minutes. If you want, then actually we can actually continue. So this is the mass then when he becomes symptomatic and he is presented. So earlier it was very small. This is the chest X-ray, which was just like looking like miliary tubes, and you can see that all these patterns can actually also seen in the malignancies like this. You want to continue, or shall we? If there are any questions we would like to take. Yes, please.
The first case of superior sulcus tumor, may I know what are the exact subset of the patient where we would like to plan pre-op CTRT followed by surgery?
So all superior sulcus tumor we give NACTRT. There are 2 papers on this subject. So they have shown that with NACTRT your local control, disease-free survival is better. So if definition wise it is going into criteria of superior sulcus like first rib or your vessels or vertebral body, then it is NACTRT.
And what is the reason when in this patient they plan CTRT definitive? I mean, what was the criteria of unresectability in this patient?
So there are 2 things. One is patient is symptomatic for brachial plexus involvement, plus there is on MRI there is a significant infiltration into plexus. If you plan for surgery, anyway you are going to shave off from that area, or you will injure resulting into a significant morbidity, upper limb weakness, or maybe permanent palsy kind of. And CTRT is equally effective, so why give such morbidity and subject patient to things? So that's why.
Anyone else is having any questions? I think everybody is hungry and the time is also up. So thank you all the panelists for participating, and all the audience. Thank you so much.